Assalamualaikum and good day to the lecturers and all my fellow friends. We are from Group 4 under supervision of Associated Professor Dr. Dayang Fredalina Basri. So now, I will pass to other my group members to present our case study.
Next, I will go for the patient medical history. Patient name is Mrs. N. She is 68 years old. She is 163 cm tall with a weight of 92.98 kg. Her BMI is 35.3 kg per meter square, which is obese, class 2. She is presenting to her primary care physician with complaint of fatigue, polyuria, polyphagia, and polydipsia for the past few months. She confirms that she has a family history of diabetes on her mother's side. She also personally had given birth to a child weight of 4.08 kg and has arthritis of her bilateral knees. Result of her fingerprints shows a blood glucose level of 198 mg per deciliter. So this is the result of her further lab investigation. The value of patient HbA1c is 8%, which exceeds the 5.6%. So it is in the diabetes range. For value of fasting blood glucose is 195 mg per deciliter, which in the diabetes range. The 2-hour glucose level value is 160 mg per deciliter, which in the pre-diabetes range. It also shows high triglyceride value and high low density lipoprotein value. For high density lipoproteins, it is lower than the normal range for women. The liver function test and renal function test is within the normal limit.
Based on additional information given, what is the diagnosis for Mrs. N? Give your reason. So before we get down to the diagnosis, allow me to explain the function of each test carried out in this case. The first one is HbA1c test, or the glycated hemoglobin test. This glycated hemoglobin is formed from the glycation of hemoglobin with glucose in the blood. So this test gives overall picture of average blood glucose level that have been over a period of weeks or months. So the amount of glucose that combined with the hemoglobin are directly proportional to the amount of glucose in the blood. Moving on, next one is the blood glucose level. Blood glucose level refers to the concentration of glucose at that single point of time or the current glucose level in the body. So the method of measurement of blood glucose level, you can always use the finger prick method, which is the convenient method. So however, usually blood glucose level refer to fasting blood glucose.
Postprandial glucose level. Basically, the word postprandial means after a meal. Therefore, postprandial glucose level refers to glucose concentration after eating. The glucose concentration begins to rise 10 minutes after the start of a meal as a result of absorption of dietary carbohydrates. It is normal for the blood glucose level to rise slightly after eating, even in non-diabetic people. Let's move on to elevated postprandial glucose level. The normal range of postprandial glucose should be less than 140 mg per deciliter. But in this patient, the postprandial glucose is 160 mg per deciliter, which is high. Elevated postprandial glucose is earliest abnormality in type 2 diabetes. It contributes to elevations of HbA1c. Let's have a look at the possible causes of high postprandial glucose level. First, unusually high intake of carbohydrate diet. Second, in type 2 diabetic patients, peak insulin levels are delayed and are insufficient to control postprandial glucose. Liver doesn't stop sugar production as it normally would after a meal and stores glycogen. Due to beta cell dysfunction, there is low insulin and high glucagon levels increase hepatic glucose output. As mentioned earlier, HbA1c is a measure of the degree to which hemoglobin is glycosylated in erythrocytes and is expressed as a percentage of total hemoglobin concentration. HbA1c test measure of average blood glucose levels over a period of last 3 months. Elevated postprandial glucose concentrations may contribute to suboptimal glycemic control. Postprandial glucose levels correlates the best with HbA1c. When postprandial glucose is high or its control is poor, it is more likely to get high HbA1c above recommended range.
Next is lipid profile test. Lipid profile test consists of a level of total cholesterol, triglyceride, low density lipoprotein, or known as LDL, and high density lipoprotein, HDLs. Another test is liver function test. It detects, evaluate, monitor liver disease or liver damage. It usually measures the GGT. GGT refers to gamma glutamate transferase. It is an enzyme that mainly found in the liver. So, if there is a liver damage, the GGT will leak into the blood, causing the GGT level to be elevated. So, another measurement is ALT, AST, ALP, bilirubin, albumin, total protein, and proton time. So, last but not least is renal function test. Renal function test, we use it to assess the kidney health and also the kidney function. Usually, the renal function test will measure the creatinine, urea, uric acid, anion gap, total carbon dioxide, sodium, potassium, chloride, calcium, and phosphorus level in the blood. Alright, so this flow shows how we diagnose Miss N based on her symptom and also the additional information given. So the symptom of diabetes such as fatigue, polyuria, polyphagia, polydipsia, together with blood glucose level of 198 mg per deciliter, is not the definitive diagnosis of diabetes, and thus further test is required. So for the further test, we assessing her blood glucose level, the lipid profile test, and also assessing her normal function of organ. For assessing the blood glucose level in the blood, we using the tests such as HbA1c, fasting blood glucose, and also 2 hours glucose level. All of these three reading shows that this patient is having diabetes. So for the lipid profile test, we assessing the triglyceride level, low density lipoprotein, which is LDL, and high density lipoprotein, which is HDL, which all of these three readings shows that this patient having a dyslipidemia. So another test, which is the organ test, we assessing the liver and the renal function test. These two tests shows that this patient having a normal liver and also renal function test, which indicate that diabetes is not secondary to the underlying disease. Okay, so diabetes and dyslipidemia, together with her history of having a family history of diabetes and previous gestational diabetes, and also the fact that this patient is also obese or overweight, which may indicate that this patient is having insulin resistance or type 2 diabetes. Okay, having this kind of diabetes also give which is cause her to having a symptom such as fatigue, polyuria, polydipsia, and polyphagia. The fact that this patient is also obese and overweight, which is the causes for her to having arthritis. Moving on. Okay, this flow shows the differential diagnosis for diabetes. So the finger prick blood glucose shows the reading in this patient is 198 milligram per deciliter, which is the reading is too high. Which is also indicate diabetes. But however, it is not the definitive diagnosis for diabetes, and that's why the further test is required. So we assessing the HbA1c, fasting blood glucose, 2 hours glucose level, the triglyceride, LDL, HDL, together with liver function and renal function test. All of those readings shows that this patient is having diabetes. However, there are two types of diabetes. By taking a measure of her family history, having an obese and overweight, also with her age is over 40 years old, with low level of HDL, and has previously developed the gestational diabetes. So this patient may having insulin resistance, which is type 2 diabetes mellitus.
There are two further tests that can be used to further confirm if the patient is having the diabetes mellitus type 1 or type 2, which are C-peptide test and autoantibody test. C-peptide test is measure the level of C-peptide in your blood. C-peptide is the substance made in the pancreas along with the insulin. It can determine how much insulin body is making. So, if the C-peptide test value is negative, the patient is confirmed to have the diabetes mellitus type 1, because diabetes mellitus type 1 is when the body cannot produce insulin due to the autoimmune destruction of beta cell in the pancreas. So, if the value of C-peptide test is normal or higher, it indicates the patient has diabetes mellitus type 2 because diabetes mellitus type 2 is when the body cannot use the glucose properly due to insulin resistance. Next, for autoantibody test, it is used to differentiate between diabetes mellitus type 1 and type 2. If it shows the positive result, it indicates the patient has diabetes mellitus type 1 due to autoimmune response. After that, Mrs. N is referred to an ADA-recognized diabetes education program. At her 3-month follow-up appointment, the patient HbA1c level has increased to 8.6% and her fasting blood glucose level is 205 mg per deciliter. She stated that she did not attend the education class as recommended, but attempt to limit her sugar intake. She also not starting the exercise program because of her arthritis. The patient is prescribed metformin 500 mg each evening and water aerobics for exercise. After 1 year, the doctor prescribed metformin 100 mg twice a day.
What is the rationale for prescribing metformin to the patient initially, and why did she not obtain satisfactory result with metformin? Metformin. Metformin is the first-line drug to treat type 2 diabetes mellitus. It is used to lower hepatic glucose intake through a reduction of gluconeogenesis and raise target cell insulin sensitivity. It is used to boost glycemic balance in individuals with type 2 diabetes. It also used in conjunction with diet, exercise, and behavioral improvements such as weight loss. High blood sugar control can help reduce kidney failure, paralysis, nerve complications, muscle weakness, and sexual function issues. Diabetes management will also reduce the chances of having a sudden cardiac arrest or stroke.
Every drug has their own side effect. For metformin, the most important side effect that could occur to the patient is heartburn, stomach pain, nausea, bloating, diarrhea, constipation, and weight loss. The patient could also have serious side effects like lactic acidosis, anemia, and hypoglycemia. Doctors need to consider a few factors before giving drugs to the patient. First, efficacy of drug. The efficacy means the ability of the drug to treat a certain condition that patient has. The next factor is the side effect of the drug. Even every drug has their own side effect, but the doctor need to consider to give least harmful drug to the patient. Patient acceptability and cost also need to be considered so that the patient could proceed with the treatment and continue to taking the drug.
Glyburide. Glyburide is a diabetic treatment for blood sugar levels and diabetes type 2 regulation. This anti-diabetic drug works by inducing the secretion of insulin to accelerate. Insulin is a hormone that regulates blood glucose level by raising blood glucose intake by tissues and increasing glucose storage in the liver. If metformin is not efficient enough in reducing blood glucose to optimal level, glyburide may be used in combination with metformin to control the glycemic balance in type 2 diabetes mellitus patient.
At her next 3-month follow-up appointment, Mrs. N has HbA1c level of 8.8%, claims to be sticking with her meal and exercise plan the majority of the time. Although the metformin achieved a small decrease in her blood glucose level, she has not obtained satisfactory result. The physician prescribed glucagon 2.5 mg per 500 mg in the morning and continues with metformin 100,000 mg in the evening. Mrs. N returns for a 3-month follow-up. Her HbA1c shows a decrease with the result of 8.1% and a fasting blood glucose level of 110 mg per deciliter. The physician stressed the need for her HbA1c level to be less than 7% and they agree to change therapy to glucagon 2.5 mg per 500 mg twice a day. The patient agrees to wake up at 3 a.m. at least twice in the first week to test her morning blood glucose level to assess for nocturnal hypoglycemia.
Next, compare and contrast the pharmacology of metformin and glyburide. First and foremost, the mechanism of action. Metformin works by reducing the amount of glucose that is produced by the liver by stimulating the cells to absorb glucose from the bloodstream, while glyburide works by stimulating the secretion of insulin from beta cells in the pancreas, which help to reduce high blood sugar levels. This is due to metformin came from bigonides class, while glyburide came from sulfonylureas class of drugs. Okay, both metformin and glyburide does give side effects. So here, the difference between metformin and glyburide for the prevalent side effect is metformin does not result in risk of lowering the blood sugar because metformin does not stimulate the pancreas to produce insulin, while glyburide more likely to cause hypoglycemia compared to metformin. This is because glyburide stimulate the pancreas to produce insulin. Okay, next we look into the pharmacokinetics. Metformin is not metabolized and is excreted unchanged in the urine with a half-life of 2 to 14 hours, while glyburide is 50% excreted in the urine and another 50% in the feces with a half-life of 4 to 13 hours. Okay, for the similarities, both metformin and glyburide are used to treat type 2 diabetes, but metformin should not be used for the patient with type 1 diabetes. And lastly, both metformin and glyburide will be consumed orally.
So now, moving on to the next slide, why the patient still advised to continue metformin 1000 mg in evening despite starting on glucagon. So, the answer for this are because the glucagon prescribed in the morning are basically to decrease the blood glucose level close to the optimal, but the postprandial levels remain elevated and her HbA1c levels will remain suboptimal. So, that's why metformin prescriptions will continuously prescribe in the evening because of metformin mode of actions itself, which are decreasing the fasting blood glucose and midday blood glucose by decreasing the liver productions of endogenous glucose. And the next one are to decrease the insulin resistance.
This answer is for question 7. It is very important to determine the presence of nocturnal hypoglycemia as an awareness. Nocturnal hypoglycemia is a condition when low blood sugar that occurs overnight while sleeping. Individuals with diabetes that treated with insulin are at increased hypoglycemic risk because when taking too much insulin than your body needs it will cause increase in glucose uptake from blood and resulting in hypoglycemia. Unawareness hypoglycemia, especially during night, will cause severe hypoglycemia and also cause convulsions and also coma.